A strange idea sits at the heart of medicine. The same thing that can save a life can also cause harm. A drug can stop searing pain, but it might also damage the liver over time. A complex surgery can cure a life-threatening disease, yet it can also introduce a new and unexpected problem. We chase a cure, but we must always be mindful of the cost it exacts on the body and spirit. The line between a remedy and a poison is often a matter of dose timing the unique biology of the person receiving it. Think of a common plant from long ago. In the hands of a skilled herbalist, it could be used to soothe a fever, calm a restless mind. But in the wrong dose or given to the wrong person, that same plant could become a potent poison. History shows us how our understanding of this balance has changed over time. The story of medicine is a long and often painful journey of learning how to manage harm. In centuries past, doctors wielded treatments like bloodletting mercury with great confidence but little evidence. These interventions were based on theories about bodily humors and imbalances. For some ailments, perhaps by sheer chance, they seemed to work. For many others, they likely hastened the patient's decline, adding a new layer of suffering. The concept of a controlled trial was still centuries away. Harm was often discovered only after it had become widespread. When X-rays were discovered, they were hailed as a miracle, used enthusiastically, even for trivial purposes like fitting shoes. Pioneers, working without protection, suffered burns, skin cancers, other radiation-induced illnesses. Learning safety was slow and painful. Our methods for evaluating harm have evolved dramatically. So in our modern era, how do we judge what is an acceptable level of harm? The first and most obvious way is to look at the data. We use the tools of statistics to quantify risk and benefit. In 1,000 patients, how many will see their disease cured or improved? How many will experience a mild side effect like nausea? How many will suffer a severe, life-altering complication? We calculate survival rates, response rates, the frequency of adverse events. These numbers are the bedrock of evidence-based medicine, a common language that helps doctors, regulators, and patients compare treatments. Agencies weigh benefits versus risks. Insurers assess effectiveness for coverage. But numbers do not tell the whole truth. A 5% risk feels different if it is your mother, your child, or you. Statistics describe populations, but harm is deeply individual. A second way, ask the person directly affected. Patient autonomy, through informed consent, is a cornerstone of ethical care. The decision to accept medical harm is never just a logical calculation. It is a profoundly emotional journey shaped by hope, fear, duty. A serious diagnosis can feel like a verdict. The promise of a new drug or procedure can feel like a lifeline. Hope can obscure the reality of side effects. The desire to live, to see a child graduate, to have one more summer, can lead to risks others might deem unreasonable. Families are torn between protection and fear of the wrong choice. They watch painful treatments, a surge of hope with good news, despair with setbacks, fear of the disease, fear of the cure. Doctors are taught to first do no harm, yet must also heal and offer the best options. Every prescription accepts risk. Every surgery accepts complications. They share hope for a cure and feel the sting when harm outweighs good. Given the complexity, how can we create a clear, ethical framework for these choices? We need a moral compass where healing and hurting overlap. We cannot eliminate harm entirely without abandoning effective treatments. Our goal? Harm must be small, measured, checked by consent and fairness. Move beyond simple risk-benefit to deeper ethical considerations. Break the question into 3 parts. First, is the expected benefit significantly greater than the potential harm? The benefit must be real, substantial, and likely, not merely theoretical or marginal. Second, autonomy. Does the person who bears the risk understand and agree? They need honest explanations of potential good and bad, free of coercion. Third, fairness. Are burdens and benefits distributed justly? Do vulnerable groups bear risks while benefits flow to the wealthy? Guard against unfair burdens. A choice is ethical only if effective, consented to, and fair. This rule is not perfect, but it is robust. Imagine a simple, quiet scene that happens thousands of times a day around the world. A patient, let's call her Sarah, sits in a small, sterile room. Her husband sits beside her. The doctor holds 2 pieces of paper. The low hum of ventilation, otherwise silence. This room contains medicine's immense debate. One paper lists facts about the standard treatment, survival statistics, odds of remission. The other outlines a more aggressive therapy, more potential benefits, higher chance of cure, but more and more severe harms. There are known risks and unknown risks.
What is most important to you?
And what about working during treatment? What will the fatigue feel like?
She is not just processing data. She is imagining a future, weighing years against months of sickness. Costs. What if it fails? Here the paradox becomes concrete. A clear choice must be made. A known risk is accepted. Healing is a delicate dance with harm. Intentional, minimal, transparent, and, when possible, chosen.